So just bear with me. So barbiturates work exactly, well, not exactly, but very similarly to benzodiazepines. As you know, they work primarily by increasing the frequency rather than benzos, which make it remain open for a longer period of time. But I just want to point out how different the places are. Now, this is the GABA receptor, which all of you, I'm sure, remember from medical or nursing school. I want to point out to you that there are differences in the various composition of the receptors. It's not as easy as we sometimes think about. There is a pentanomer, so there's 5 positions to that, which you can see here, and there's always receptors for barbiturates, receptors for benzodiazepines, and the own GABA receptor. There's always 2 between the alpha and the beta receptors, right? But that requires that there is GABA available. The other thing that you have to remember is that different benzos do different things, right? So some benzos tend to have much more muscle relaxant effect. Valium is a good example of that, as opposed to, let's say, Xanax, which is a much better anxiolytic than a muscle relaxant. And some of them, like lorazepam, are very good antiemetic medications because of these different properties in the composition of the GABA receptors. So not all GABA receptors are created equal. Now, benzos are not created equal either, and this is from that paper I wrote a few years ago that people were quoting me about. These are the benzos. These are the equipotencies, and as you see, a vast difference between alprazolam, where 1/4 of a milligram of alprazolam is equal 5 milligrams of diazepam or Valium. But the other 2 differences have to do with the half-life. So think about that. Which benzo is better, Librium or Valium? Which one do you like? Oh, come on, I know you use benzos, because that's why they invited me here. Somebody said Valium? Okay, so that's Valium. This is a metabolism. That's Librium, chlordiaz epoxide. What's the difference? This is metabolized into that, which is metabolized into that, which is metabolized into that. Same crap. Different half-life. Not that much better from each other, right? So, of course, this one has slightly longer half-life because there's more intermediaries in between the 2 of them. But benzos are really not that different from each other, and they're not the best medications. Of course, if you have somebody who is drinking a lot, the oxidative pathway goes out relatively easy. So you rely only on conjugation, which is what we use only temazepam, oxazepam, and lorazepam on a chronic alcoholic. And that's also important because some of the CWA protocols require that you know the patient's metabolic status to choose which benzo you want to use. So as I said, I used to dabble on benzos, and we did a few studies on benzos. I trained in Boston, came to Stanford. They like short-acting benzodiazepines here. And I was trained in Boston where we use a truckload of Valium. I mean, I used to carry Valium in my pocket and just give it to alcoholics or attendings, depending on who was more anxious. So we decided to do a study where we were comparing the loading method, where you give somebody a long-acting benzo, versus a CWA method, which is symptom trigger. Which one do you think won? Short-acting, long-acting. CWA versus loading. Who thinks what? Come on.
The symptom trigger.
The symptom trigger. Why do you think it's better?
Well, because you're going to treat them as they do things, not by the vitals aren't always accurate.
Okay, anybody wants to argue with her? Come on. See, this is why we need alcohol, huh? What? You agree with her? No, I want somebody to disagree with her. But she's talking about the CWA-based protocol. Symptom trigger is CWA, right? So symptom trigger, that's the same thing that CWA does. But they say, by the way, CWA sucks. Just remember that. Benzos are bad, CWA sucks. I'll give you a few more mantras. And I'm not running for president. Anyway.
Please do.
Oh, no. Oh, I can't. I'm a foreigner. So. Anyway, okay. So bottom line, compare the 2 of them. Guess what? They're both equally bad. Neither one. Now, which one do you think patients like of the two methods? They prefer the loading method. Why? Because they got 100 milligrams of Valium up front, and they had it on them, and they were happy. Which one do you think the nurses liked? The loading method, because they were just giving you 20, 20, 20, 20, and then after that, you have to talk to the doctor. So, but they were exactly the same. The CWA protocol was absolutely not better in any way than the loading method. Now, this is a patient that I got from you. This is a few years back. I think it was 5 years ago, so you might recognize the patient. On 10-1, a patient was involved in a fist fight somewhere near here. I believe that Clay is taking me to that bar later today. And in the fist fight, somebody got punched in the eye, the left eye, so they broke the orbit, was admitted to Dominican Hospital. There was some reported loss of consciousness, but it was not well described. No blood alcohol level of tox screening was performed by you. Don't feel bad. Stanford didn't do it either. These are the patient's vital signs, relatively normal, slightly tacky, but slightly tacky. And then he had a history of BAD, whatever that means. I mean, I know it means bipolar affective disorder, but I don't know what exactly the chart meant by that. Later that night, the patient was transferred to Stanford because they needed a plastic surgeon to repair the orbit. Again, no blood alcohol level was done. The next day, the intern comes in, get a blood alcohol level, which was 71. Just start counting how many hours that was later. Patient was acutely intoxicated, and he had a KH of 4 out of 4, which is as high as you can get. So this is what happened to the patient. On the first day on admission, we gave the patient 1 milligram of lorazepam. I don't really know how many you gave before you transferred the patient, but on the second day, he received 100 milligrams of diazepam equivalent, and the next day, 150 milligrams of diazepam equivalent, and the next day, another 150, and then they call a psych consult. We went to see the patient. We put the patient on the benzo sparing protocol, and as you can see, the patient received no more benzos thereafter, right? And this is one of those things that I want to make a remark on today. The benzo sparing protocol is not perfect, but it works extremely well. Now, why is it that I hate benzos so much? Well, I'm giving you 10 reasons here, right? It interferes with normal patterns. In fact, as you know, all sedatives decrease REM rhythm, so you create REM rebound. There's a huge liability potential with benzodiazepines. About 76% of the patients who use alcohol will love to have a benzo. The brain sees it very much in a similar way. So it is like going from heroin to methadone, alcohol to a benzo. It interferes with cholinergic functions. All benzodiazepines have anticholinergic side effects, and that means that it will both impair memory and increase the risk of developing delirium. They cause psychomotor retardation, cognitive blunting, etc., and it causes a number of other problems. But let's move to why I really hate benzos. This is from Pratik Parandepinde at Vanderbilt, showing that as you increase the dose of benzodiazepine per day, and the magic number is about 6 milligrams of Ativan a day, you have a significant increase in the risk of developing delirium. So you're more likely to treat the alcohol withdrawal and cause a delirium than you are of anything else, right? And remember, we are usually over-medicating about 20% of the patient. And then the last one, the 10th reason is this. This is from Ted Stern and his colleagues at MGH. They came up with what they call the pathway protocol, by which, based on the patient's sex, age, metabolic status, they choose which of these pathways patients go to. So they match the best benzo with the best patient. And guess what the incidence of benzodiazepine-induced delirium was? 42%. So you are likely to prevent the patient from having alcohol withdrawal, but you have over a 40% chance of making the patient delirious. So one of the things that we discover is that when we look retrospectively at my own data using benzos, we actually had a very successful rate of treating alcohol withdrawal. Our patients were staying in the hospital about 7 days later or longer because we were causing delirium. Yes?
Oh, the previous slide where you had the graph and you were talking about how many milligrams per day. This graph, is it like the other graph where you start adding up each day, so the total number, or is it?
Well, this is using lorazepam, so there's no accumulation on lorazepam. That's per day.
Are you saying the person is eventually receiving 40 milligrams of Ativan a day, or is that the total, like you're adding up day by day?
Yeah, that's a great question. So you have an 80% chance of causing delirium by 6 milligrams a day. So as you get to 40%, you essentially have 100%. Per day. There's no accumulation with lorazepam because of the half-life. So of course, on diazepam, it will be significantly different because there's accumulation, right? Half-life of lorazepam is 8 to 12 hours. The half-life of diazepam is about 100 hours. Yeah?
Is it hard to distinguish between the delirium from alcohol withdrawal and the delirium from...
No, and that, see, it's like I pay her to ask that question. Yeah. Okay, so 2 reasons I hate CEWA. 1, did you guys know how CEWA was created? You're not that far from the birthplace of CEWA. Bunch of rich people wearing Napa, sitting around the fireplace, going through alcohol withdrawal and treatment, and then they're saying, you know, I have a headache. Oh, good idea. They add headache to the CEWA. And look, I'm shaking, so they add shaking to the CEWA. How many vital signs there on CEWA? 0. There are no vital signs on CEWA, period. That's one problem. The other problem is this. If we're using Benzos to treat alcohol withdrawal, I already told you, the data shows 40% incidence of delirium. If a patient becomes delirium, that will make them CEWA positive because all the symptoms that we mark on CEWA are mental status alteration. They have no vital signs. So if, as we have experienced, you have a patient who is, let's say that I had a history of alcohol withdrawal, of alcohol abuse, and I quit 5 years ago. But now that is on my record. I'm going to 17, have a motor vehicle accident, get admitted to Dominican, somebody goes, history of alcohol use, put him on CEWA. If I start getting delirious, CEWA will be positive. You're going to give me more Benzos. I'm going to be more delirious, and then the cycle continues to, perpetuate itself. That's the second reason I don't like CEWA. Nothing against the author. I'm sure he'll criticize my protocol itself. Third, more important slide of this talk is this. How is it that we get in trouble with alcohol abuse? Well, this part is that the part that I know you guys all know, right? Benzos bind itself to the GABA receptor, to the GABA complex, not the receptor, and then have an allosteric effect on GABA. So it augments the effect of GABA. And all GABAergic medications, benzodiazepines, barbiturate, and propofol, will do exactly the same. But that's not the entire story. This is all the things that alcohol does. It inhibits glutamate receptors. That means that your body is going to produce significant more amounts of glutamate. It disinhibits GABA-mediated dopamine projection, so you're going to dramatically increase the amount of dopamine. It decreases the availability of acetylcholine, so you're going to have low levels of acetylcholine, melatonin, etc. So at the end, the story is not just GABA. And in fact, if you look at that, GABA is the smallest component of the entire problem of alcohol withdrawal. So the reason our protocol uses 0 GABAergic agents is because you can manage everything dealing with all the significant problems of alcohol withdrawal. Now think about it. What are the symptoms of alcohol withdrawal? Seizures caused by excess glutamate, not decreased GABA. Tachycardia, which is caused by norepinephrine excess. Norepinephrine. And glutamate. Glutamate, right? GABA is not really related there anywhere. So now let's think that this is the acute alcoholic. Let's talk about the chronic alcoholic, and I don't have enough space on the slide to do everything. But if you're drinking a truckload of alcohol, eventually your GABA-A receptor adapts itself. How is it possible that when you started college, you will get drunk after 2 beers, and by the end you finish college, you could drink an entire keg? How do we do that? She goes like, yeah.
Downregulation of receptors.
Exactly. That means less availability of GABA activity. So you downregulate receptors. There is encapsulation of some of the receptors. Remember that I told you that there are different portions of the receptor that have different sensitivities? So it decreases the sensitivity to both alcohol and benzos itself. And the key is this. You produce less GABA itself. Your brain speedballs. You know what speedballing is, right? If you love to do cocaine, what else do you have to do? You have to add some heroin in order to balance itself. And if you love heroin, you have to use some speed, right? That's speedballing. Your brain does the same thing. So it decreases the amount of CNS depressant activity by reducing the production of GABA. And remember the two key principles. The reason your patients, even though you're giving them the right medication, a benzo, they still withdraw is because the benzo is hitting the receptor. There's not enough GABA, the second key, to activate the receptor. That's why your patients will still go through withdrawal despite of giving them a benzodiazepine. So you make them more delirious, you're not preventing that much more alcohol withdrawal. But again, that's only half of the question. Then you have dramatic increases on glutamate. That's a speedballing, right? You increase glutamate, you increase norepinephrine, then the patient can't stay awake despite of using all that alcohol. And then the other thing is this. Alcohol itself desensitizes the alpha-2 receptors, which means that you produce dramatic amounts of norepinephrine. Again, the patients suddenly stop drinking, diaphoretic, tachycardic, dilated pupils, hypertension, and eventually hypertensive crisis and seizures. All of that is mostly norepinephrine and excess glutamate. This increase in dopamine, I don't care. In fact, the data shows that if you reduce the excess norepinephrine, you actually reduce the excess glutamate. And I thought I had a graph on that. But it is the excess glutamate what causes the seizures and some of the confusion. It is the excess dopamine that causes the hallucinosis. It is the excess norepinephrine that causes 85% of the symptoms of alcohol withdrawal and some of the agitation. And this is, I'll be right there. And this is just to point out, there are studies that show that if you block the excess norepinephrine by using something like dexamethasone, you actually dramatically reduce the excess glutamate. So some of the data that I'm going to show you shows that if you only use an alpha-2 agent, you actually can prevent over 90% of the seizures. Go ahead.
So if somebody's on a GABAergic medication chronically, like Neurontin, let's say, would they have that same possible likelihood of increased withdrawal for GABA depletion?
So the question is, if somebody's in a chronic GABAergic medication, are they at risk? The answer is yes. But gabapentin is not a GABAergic medication. Gabapentin works by glutamate, not by GABA. So it's a nice trick that the firm makers of gabapentin has done on making us believe on GABA. But I'm going to get to that. In fact, I use a lot of gabapentin because of the effect on glutamate, not because of the effect on GABA. Anyway, does that make sense? It's important we understand this because everything else has to do with that. So you can treat it all by using an anticonvulsant agent that works by blocking the excess glutamate or the calcium channel receptor. You can use an antipsychotic if you want to. I'm a psychiatrist. I never use antipsychotics to treat alcohol withdrawal. Even the symptoms of alcohol withdrawal disappear. I mean, the psychotic symptoms tend to disappear with our benzo sparing protocol. And then the basis or the broth of our protocol is an alpha-2. Alpha-2, I think, are among the best medications that we have, at least in the north of the neck, than anything else. So alpha-2 is the basis of that. And then I just want to point out the issue of chronic insomnia and chronic sleep deprivation in patients with alcohol withdrawal. You see that one of the things that happen when you're going through withdrawal is that you shift the metabolism of L-tryptophan. This IDO gets promoted, so you produce less serotonin and less melatonin, which is why alcoholics are, most of them, depressed, and all of them have a sleep deprivation. And then instead of that, you go through this pathway that causes all kinds of neurotoxic particles, which is one of the problems with chronic cognitive impairment on patients who drink. So the chronic cognitive impairment and eventually leading to dementia has to do with the production of toxic metabolites and the lack of availability of acetylcholine. So the other way to think about alcohol withdrawal is this. There's some inhibitors, like GABA, which is less available. There's less magnesium, less serotonin, and less melatonin. There's tons of psychostimulants that your brain is producing in order to speedball or offset the effect, the sedating effect of alcohol. And then you have all the syndromes that go with it. If you look at the syndromes, none of them have to do anything with the presence or the absence of GABA. So GABA mediates the rest of the imbalance of the brain, is not the cause. It's just a mediator. Now, having said that, I'm telling you that I only care about 20% of the patients. I really, really care about that 20% of the patient. I don't care about the other 80%, and some people might even say that I'm a bit cruel, because I know they're not going to progress, so I don't pay as much attention to them. But this is why I care about the 20%. Every time somebody goes through alcohol withdrawal, it lowers the tendency for the next episode of withdrawal. So the reason we have a prophylaxis protocol for alcohol withdrawal is because you don't want patients to go through that. You want to obliterate it and not have them go through them. And I'm going to show you our protocol has both a prophylaxis and a treatment. I'm going to go over the actual medication so you understand why is it that we use them. For a calcium channel modulator or a glutamate anti-glutamatergic agent, all or most of the anticonvulsants will work. When we created the protocol back 7 years ago, I used valproic acid because valproic acid is available by mouth and intravenously. Carbamazepine was not available back then. There's very good data on both agents. Nowadays, carbamazepine is available IV, so you can use that. And then, of course, you see gabapentin, which unfortunately is only available by mouth. We don't have time to go through each one of these studies, but I sent Karen we have a very comprehensive review article that has every study of every medication that has ever been tried and summarize it, and you have the slides. So I just want to highlight the ones on yellow here. As you see, first study by Malcolm comparing carbamazepine with benzodiazepines showed that benzodiazepine and carbamazepine were exactly the same. There was no significant difference between the two of them. Stuapek and colleagues, a benzodiazepine against carbamazepine, you see that there's no clinical difference between the two groups, and in fact, a greater progression to DTs and seizures on patients on the benzo. So this is benzodiazepine. The risk of DTs was 7% as compared to 3% on carbamazepine. The incidence of seizures was 0% on clonidine and 0% on oxycarbine, so about the same. Malcolm did a study again comparing lorazepam versus carbamazepine, and as you see, no significant difference between the two groups. And then Minosi and colleagues shows that carbamazepine was slightly better than benzodiazepines. I use valproic acid for the reasons that I already mentioned. Longo and colleagues did a study looking at the difference between the two of them and suggested that valproic acid was as good as benzodiazepines on the treatment of alcohol withdrawal without causing the problems of the confusion that benzodiazepines do. So a meta-analysis showed that valproic acid was more effective than carbamazepine, and again at the time, valproic acid was also available IV, so that's what we use. Gabapentin had actually shown to be extremely good. So as alpha-2 agonists as anticonvulsants come, it is a very good medication. You have to use high dosing. So as you see, the first day, you use 1,200 milligrams of carbamazepine loading and then 800 milligrams TRD. And when you compare that with phenobarbital, there were no significant differences between using gabapentin and phenobarbital. American colleague, and he did two very good studies showing that if you use low dose versus lorazepam, they were both equally crappy, but high dose gabapentin was superior than both low dose gabapentin and low dose lorazepam. And then Stock and colleagues showed that there was no significant difference, but none of the bad side effects of patients using benzodiazepines. So now to my favorite medication, which is the alpha-2s. I already point out to you that if you lower norepinephrine, you lower glutamate. So one way to hit both systems is by using the alpha-2 system. And I just want to point out, I'm sure that you use all kinds of beta blockers, and I just want to point out, beta blockers do not work, period. So don't confuse what I'm saying today. Beta blockers don't work. Beta blockers will actually mask the symptoms without preventing alcohol withdrawal. And it has to do with the mechanism of action. Think about what I said. If you have a massive amount of norepinephrine being released that left the receptors, now it can hit anywhere, including producing a significant increase and release of glutamate. A beta blocker only works on the postsynaptic receptor. It doesn't touch glutamate. So beta blockers don't work. Alpha-2s work on the presynaptic receptor, so it actually reduces the amount of norepinephrine being produced. So you have no excess norepinephrine being released, and it cannot then influence glutamate. Does that make sense? Beta blockers don't work. We have no beta blockers in our protocol. It's only alpha-2. These are all the alpha-2 availables in the market. The only 3 that we have in the United States are guanfacine, Dex, and clonidine. 2 things to point out. If you look at clonidine, this is the alpha-2 versus alpha-1 effect. Clonidine is 220. Dex is 8 times better than that. And guanfacine is about 6 times better than that. So guanfacine is the best medication we can use. Our protocol uses clonidine. And the reason for that is I don't trust alcoholics. So you can give somebody a clonidine patch. Guanfacine requires that you take the medication. So that's the only reason. Now, honestly, if my brother was an alcoholic and was going through alcohol withdrawal, I will give my brother guanfacine, because I'll make sure that he takes it. Yes?
This week we had one on guanfacine and it reduced bradycardia. What you?
No, that.
Basically, and I.
Yeah, I love challenges like that. I will have 2 things to say. If we have a patient who is going through alcohol withdrawal, and I'm using quotation marks because it might not be true. If we have a patient going through alcohol withdrawal and we give them one of the alpha-2s and the patient crashes, develops hypotension, for example, or bradycardia, that means one of 2 things. Either the patient was hypovolemic, like a trauma patient, or the patient was not going through alcohol withdrawal. The patient might be delirious and intoxicated, but not going through alcohol withdrawal. Alcohol withdrawal, by definition, is a noradrenergic storm, and it takes a lot to bring the patient down.
I can only tell you the story.
I know.
Witness seizure in less than 24 hours, has deliberately told all his family members go to the restaurant for stopping alcohol, had other symptoms.
Yeah.
And
what did you give the patient? Guanfacine?
Yes.
How long after the guanfacine was given did the patient have a seizure?
No, the seizure was before.
Oh, okay.
Yeah, the seizure was before. That was part of the treatment program.
Yeah.
But we have some much experience here with guanfacine, so that's why I'm asking.
Yeah. But remember, I mean, I don't want to go back all the slides, but remember that the curve for seizures was here, and the curve for DTs was here, right? So, and they are not the same. One doesn't always progress to the other. So I don't disagree that the patient might have had a seizure secondary to alcohol withdrawal, and if you give them guanfacine, you will prevent the DTs, and it had nothing to do with the seizure. So it's a matter of timing.
My question was the bradycardia. Should I have not stopped it, which I basically did and started clonidine?
How many hours after the guanfacine was given did the patient get bradycardic?
About, half a day to a day.
Okay, so the half-life of guanfacine, which is, remember I said if it was my brother I will give them guanfacine. The half-life of guanfacine is too long to effectively use in the protocol by itself. And I'll go into, the half-life is 20 hours. So when we use guanfacine, we use something else. And that is the problem of using guanfacine. But when I go to the protocol, I'll try to answer your question. Guanfacine is by far the best. It is the one, despite of your experience there, it is the one that has the least hypotension and has the most anxiolytic effect. Of course, the fastest one is Dex. Half-life is 2 minutes. So 15 minutes, you get what you get. You can titrate the dose every 5 minutes and you get, every 15 minutes and you get the dose there. And then clonidine. So these are all the studies on the use of the alpha-2. I'm going to highlight, again, only the ones on yellow. And if you look at this here, comparing Librium versus clonidine, you see that there was no significant difference on the symptoms of the patient. And people did better on the AWAS, which is a competitor for CIWA, and did better on the anxiety scale. If you look at Drobinov study, look at this. Comparing a benzo, anxiety incidence is 67%. The alpha-2 was 0%. Agitation was 40% on the benzo, 0% on the alpha-2. Progression to disease, 30% of the benzo, 7% on the alpha-2. So I'm not saying that the alpha-2s are perfect. You still have nearly a 10% incidence of progression. But that is 3 times better than using a benzodiazepine without the induction of seizures. And then Lisore and colleagues did a meta-analysis and showing that the alpha-2s, that was dextromethorphan, were better. There's tons of case reports on the use of dextromethorphan. Not many good studies, and that is unfortunate. Now, I told you that 80% of the patients are not going to progress. And the question is, how do you know which patients are the one at risk? So, for example, your patient, I would have done this scale first before deciding whether to load them with an alpha-2 or not. Now, we were going to do a study where we're going to take people on a benzo protocol or a benzo-sparing protocol and give them medications that are not necessarily the most benign, right? IV valproic acid, that can ruin your liver if you give it to the wrong patient. So we wanted to tell the difference between the two of them, and we realized that there's no good predictive tool. So we did a study of what was available. This is CIWA. I asked you about CIWA before. I don't know how many of you order CIWA, but look at this. There's 0 vital signs on them. I don't like CIWA, but I love AWAS, which is the Alcohol Withdrawal Assessment Scale. 50% of the points are caused by what the patient is experiencing in vital signs, and then 50% of the points are things that you observe rather than the patient report, significantly more accurate. And this is the conversion between CIWA and AWAS. And then we decided to do a study, and this is what we found. So doing our pause, which I believe Karen reproduced for you, it's 10 questions. In our study, it took about 3 minutes to do that. And now in our hospital, all the nurses do a pause on every patient admission. The easy part is this. If the patient has not been consuming alcohol in the last 30 days, that's it. That's the end of the study. Now, if the patient has used alcohol in the last 30 days, then they have to complete the rest. And when we did the first study, it was a relatively small study, only 70 patients. The sensitivity and specificity was actually pretty good. Even my grandmother will say that 100% is probably a bit too good to be true. And my grandmother loves me. So we did a significantly larger study, 1,500 patients, and the sensitivity dropped to 93.5%. The specificity is still 99.5%. So we are very comfortable that if a patient is positive on the pause, I don't care what the patient looks like now, that patient will go through severe alcohol withdrawal. And if the pause is negative, that patient will have withdrawal, but it will not be complex or severe withdrawal. And the curve looks pretty good, and I know you probably think that I'm boasting about this. The good thing is that the New England Journal, the JAMA, the Journal of the American Medical Association, just did a study looking at every tool ever used between 1946 and January of this year. And after, I forgot how many patients there were, but there were a lot of patients. There were like 10,700 patients. Pause was by far the best, with an accuracy nearly 99%. So now we know that you can actually predict which patients are going to have severe alcohol withdrawal. Those are the patients that need to be treated. And then the other patients, you can symptomatically treat them without giving them tons of benzos. So this is what we do, and then we can talk about the treatment. So a patient comes in, we do a pause. If the patient is pause negative, that means that they will not have severe withdrawal. you can do whatever you want to with them. If the patient has a positive pause, then the next question is, are they withdrawing already or not? If the answer is no, they're not withdrawing, then we put the patient on a prophylaxis protocol to prevent them from withdrawal, because we know that they will. And if the patient, these are things, sorry, I'm not trying to deprive you. These are things that I'm sure you all do, so I'm not spending a lot of time with that. I just want to remind you that magnesium is the #1 predictor of alcohol-related seizures, more important than the baseline alcohol level. So make sure that patient is not hypomagnesemic. And the other thing that is important is for you to remember that if you suspect a patient has cognitive impairment related to alcohol, you have to give them a truckload of thiamine. The Royal College of Physicians says 500 milligrams of IV thiamine 3 times a day for 5 days. And the reason for that is thiamine levels are depleted, absorption through the GI tract in relationship with alcohol is dismal. So if the patient has cognitive impairment, you have to give them a drug. In fact, we just had a patient who was brought in by the family because he was demented and an alcoholic. We cured his dementia after 3 days of IV thiamine. So obviously he was not demented. But you have to give them a lot. So this is the actual protocol, and I was talking to some of your leadership. I'm happy to give you our order set. So positive, then you do an AWAS, which is what we use. You can use CWA if you want to. If the pause is positive and the CWA is negative, that means the patient will have severe withdrawal, but hasn't started withdrawing yet. So you put them on the prophylaxis arm. And the prophylaxis arm includes an alpha-2 agonist. Clonidine is what we tend to use because you can slap the patient with a patch. The patch lasts 7 days. Even if the patient is not compliant, you're going to stop the withdrawal. Now the problem is this. Clonidine, just like Wanfacine, if you give Wanfacine PO 20 hours half-life, that means that it will take 3 days to build up. The transdermal patch doesn't become really bioavailable until 18 hours later. So even though we give the patient a patch, you have to give the patient either IV or PO clonidine now, and 8 hours from now, and 8 hours from now. Does that make sense? That way you're covering the patient for the first 24 hours until the patch kicks in. If you're using Wanfacine, you have to do it for 3 days. So even though I love Wanfacine, that's the limitation of Wanfacine.